Welcome everyone. I'm Tom Gallagher. I'm professor and associate chair of the Department of Medicine at the University of Washington and also executive director of the Collaborative for Accountability and Improvement. And it is my pleasure to welcome you to our webinar today on COVID-19 and medico-legal liability, reports from the front lines, challenges for tomorrow. For those of you who don't know, the Collaborative for Accountability and Improvement is a national program based at the University of Washington dedicated to the spread of high-functioning communication and resolution programs. Our goals today are really for you to hear from four leading voices who are experiencing COVID's impact on healthcare delivery from different perspectives, from the perspective of the patient and family advocate, the risk manager, the liability insurer, and the defense attorney. We have a packed agenda today, so we're going to move through things relatively quickly. I'm going to, after I briefly introduce each of our panelists, they will have 5 minutes per panelist for a very brief presentation about what are some of the issues they're seeing right now, what are some of the challenges that they're envisioning down the road. We have a series of questions that I will then throw out to our panelists, and we've saved about 20 minutes at the end for your questions. So please submit any and all questions in the chat box, and we'll have an opportunity to quickly collate them, and the last 20 minutes or so, I'll send as many questions as I can to our panelists. The webinar is being recorded, so folks can look at it later. It will be very helpful if you make sure that your video is off and you keep yourself muted. We have a large number of folks signed up for the webinar, which is great, but we also want to make sure that the Zoom bandwidth is preserved. And so with that, let me quickly introduce our esteemed panelists, all of whom are board members for the Collaborative for Accountability and Improvement. Leilani Schweitzer is a patient advocate for Stanford Healthcare and is a part of Stanford's Communication and Resolution Program, which is named PEARL. Welcome, Leilani. Marcia Rhodes is the head of UW Health Sciences and UW Medicine Risk Management at the University of Washington. Mike Severin is an attorney and regional vice president of claims for ProAssurance. Before coming to ProAssurance, he was a private practice attorney defending medical professional liability claims. And our final panelist is Kyle Sweet. Kyle is an Oklahoma-based defense attorney representing healthcare providers in catastrophic injury cases around the country. So welcome to our outstanding panel, and I'd like to start with Leilani telling us a little bit about what she sees from the patient and family perspective about how COVID is playing out and its potential impact on medico-legal liability. Leilani?
Thanks, Tom. Hello, everyone. I hope everybody's having a good Friday. So I appreciate the opportunity to be here and talk about a little bit about what we're experiencing at Stanford and what we are anticipating to be coming down the road. Like everyone, we're kind of speculating about what we think is going to happen, but I think the uncertainty that COVID has brought to all aspects of our lives is really amplifying fears and worries and potentially financial concerns, not only of healthcare systems, but more intimately for patients and families as well. And these circumstances really, I feel, are an opportunity and a requirement for very clear, compassionate communication to people. And there likely will be a need to repeatedly remind patients and families of the context and the circumstances that COVID has, the challenges that COVID has created for everyone, particularly healthcare systems. Just as an aside, I think social distancing has made the more desirable practices of being able to meet with families and explain what's going on with them, particularly having conversations that involve discussing unanticipated outcomes. That is more challenging because those conversations now have to be done on the phone, or maybe they are being postponed. So that just the social distancing is, without the worries of infection, is a significant problem. I think that all of these stressors are likely going to really impact people's perceptions of what happened. So unfortunately, those perceptions will always trump the reality of an event. And where patients and families don't have the opportunity to understand what happened, those gaps in understanding that they may have will really exacerbate their poor impressions of their experience. And the flip of that is, it really is an opportunity to have these conversations with patients and families to provide them with a context and an understanding of what's gone on. I think that the stresses and the constant distraction of COVID that is being placed on the healthcare systems and the staff is going to result in an increase in events that negatively impact patients and families, though are within likely the standard of care. So things that we don't want to have happen, but nonetheless do. So things like CLAPSIs and pressure ulcers, falls, and infections, I expect those are going to go up. I think that there is going to be problems with poor communication with patients and families, again, because of all of these stressors and distractions. I expect that people who work in hospitals whose jobs are to deal with grievances and maybe deal with allegations of impractical medical care, to sort of use the parlance of what we're all hearing these days, I think our peak is probably 6 months out, where we're sort of waiting for the results of the delays that have been put in place because of the halting of elective procedures. Of the consequences of that is going to take a while for it to be revealed. So delayed diagnoses, all of those kind of things are going to take a while, and they're going to require conversations. So patients and families may attribute everything to COVID, they may not, and they're going to need a conversation to remind them of what those circumstances are. And then there is going to be even more of the constant challenge with these conversations, is explaining to patients and families how their experience may involve damages or may not, but it's still just going to require a really careful conversation. And I think that CRPs there's going to be only more value to them going forward, because not only are they valuable in cases where an outcome was preventable and it's easily understood, I think there are going to be a lot of cases where things are not going to be easily understood. There's going to need to be a lot of conversation because the perceptions of patients and families are going to be challenging. And if we can have those conversations with people before they turn to litigation, that's going to be a real advantage of explaining to them, giving them the opportunity to ask questions and clearly understand the facts of their care, will then avoid all of the expense and challenges that litigation can bring, which I think is the goal of the collaborative to try to avoid. So that's my quick assessment of trying to look forward into the future, Tom, of what I think is maybe going to happen.
Great. Thank you so much, Leilani, for those outstanding remarks. And just as a reminder, we're going to be taking questions by chat and discussing them towards the end of the presentation. So feel free to send any questions you have that way. Marcia, can you tell us a little bit about what you're seeing as a risk manager?
Sure. Thank you, Tom. I'm really, just to start, want to say I appreciate the opportunity to share experiences around COVID-19 with this group. I think all of us have been slightly overwhelmed, and we have a lot to learn from one another. I'm working at the health system level at the University of Washington and have been providing support to our incident command center. As first we ramped up for an anticipated surge and then worked into contingency standards of care. And now, like most of you, we are well into the challenges of reopening services. During this time, I've really been struck by the similarities between a well-functioning CRP and disaster management. I mean, each of them require a comprehensive, principled, and systematic approach, and they're based in the foundations of fairness, duties of care, resource stewardship, transparency, and accountability. And that's been very interesting for me. Like you, I'm getting a lot of calls. A few of them. How do we deal with the non-compliant patients? This, surprisingly for me, has caused a lot of moral distress with care providers. They have questions like, what if we have a non-COVID positive PUI patient who's an inpatient and they won't follow our social distancing or masking rules? How do you deal with that? What should we do when we have a COVID positive or a PUI patient in the ED and they threaten to leave AMA? And we know that because of behavioral health concerns or their homelessness, that they either can't self-isolate or self-quarantine or won't. Can we detain these patients? Should we restrain them? What are the rules there? In some cases, there were questions about, should we call the police? We've also received questions about advanced directives early on, particularly with patients who are being admitted and being put on a ventilator. So, typically in our state that requires the patient's a wet signature by the patient plus or a notary. And in either case, we're trying to conserve PPE, and at the time didn't have a lot of PPE available. And so there were questions about, can we have 2 witnesses sign for the patient? What's the right thing to do there? Telehealth has been a huge hot topic across the country. Questions about licensure, what about credentialing and training? Can we use telehealth modalities in novel and unique ways for inpatients to conserve PPE? And then what about all the federal waivers of law? I mean, there are questions we came up with about EMTALA and whether screening exams could be deferred from our tents. What about patient rights associated with visitor policies and that sort of thing? The one thing I didn't expect to have happen that did was that we had input about equity. So what about equity during a pandemic? Our federal watchdog group for discrimination filed a very lengthy complaint letter with the OCR about our state crisis standards of care triage guidelines. And their question was whether our guidelines really unfairly discriminated against those with disabilities. As it turns out, they never pursued that in our state, and we never reached crisis standards of care. But we know that's going to be an ongoing issue because OCR has reached settlements with 2 states, Alabama and Pennsylvania, on this score. And then in addition, we received a friendly letter from a disability rights law firm that's quite prominent, just putting us on notice that we needed to be careful about accessible technology that we were using with patients during the pandemic to make sure that the types and configurations of devices, websites, and PDFs could be assessed by the disabled. And they also warned us about our drive-up clinics and walk-up testing sites to make sure that they were accessible to those without vehicles and for those who had physical disabilities. I've also learned that some questions are really hard to answer. Surprisingly, the exposure communication decisions with patients have been difficult. And that's both because our knowledge of the virus and our infection prevention interventions are really moving targets. And we also have widespread community transmission at the same time. So it's been difficult to determine when we actually have an exposure that's disclosable. And then we have some situations where the best solutions to questions require system changes, and we're not, sometimes the system changes cost more than what we're trying to avoid in the beginning. An example of that is wet signatures to avoid contamination on paper documents that we've deferred. And finally, as Liana mentioned, there's difficult decisions about end of life, being done through telehealth modalities and that sort of thing, I think will be fodder for lots of questions. For the future, I think we need to be really concerned about delayed surgical procedures, remembering that differential in perceptions that Liana mentioned. I'm concerned about the distractions that might be affecting whether we're delivering optimal care, and then gaps or failures to diagnose with telehealth. That concludes my thoughts. I'd like to turn it back to Tom.
Excellent, Marcia. And Michael Victoroff is 2 questions ahead of everybody else, so don't fall behind. He's already submitted 2 great questions, and we'll circle around to those later. If we don't get to all of the questions today, we'll have a chance to follow up and perhaps schedule another session. So the more questions, the better. Mike Severin, what are you seeing from the perspective of a liability insurer and the issues that are coming across your desk?
Sure. From a healthcare professional liability insurance industry perspective, medical legal issues and/or concerns. For example, one new medical legal issue we are monitoring is whether or not healthcare providers or healthcare facilities will be immune from malpractice liability during the COVID crisis. I know during the COVID crisis, many states have enacted emergency orders that provide healthcare providers and healthcare facilities with civil immunity, but for acts of negligence or intentional misconduct. Going forward, providers will have actual immunity from civil liability while treating patients during the COVID crisis will be dependent upon a lot of the allegations in each lawsuit. For example, in most jurisdictions, it'll be clear that providers will not be immune from claims of gross negligence or intentional misconduct. Thus, creative plaintiff attorneys could claim gross negligence or intentional misconduct to try to get around the immunity protections. For example, a patient could allege his or her provider intentionally failed to sanitize equipment for cost reason, causing that patient harm. I also note that emergency immunity orders don't specifically bar lawsuits. Thus, anybody can still file a lawsuit. So again, if they do, they're going to be still costly to defend those claims. My suggestions to providers going forward regarding immunity issues is, number 1, continue to exercise good judgment. Number 2, don't worry too much about your civil liability. We can't control whether lawsuits are filed or not. However, what you can control is if you exercise reasonable care, there's more of a chance that you will not be found liable for your actions. Another medical legal concern that we've been seeing within our industry deals with telemedicine issues. I know telemedicine is not new. However, during the COVID crisis, telemedicine is not just for radiologists or teledocs anymore. In fact, during the COVID crisis, telemedicine billings are up approximately 800% as physicians and advanced practice professionals increase this social distancing method of care. Some specific telemedicine legal issues that we're concerned about include, number 1, technology issues. For example, sound and quality of video connections could be an issue. Thus, providers need to be planned for these kinds of issues. Another legal medical issue with telemedicine is there's a good chance that failure to timely diagnose types of claims may increase going forward. Thus, it's important that providers understand and appreciate the diagnostic accuracy of telemedicine. For example, on telemedicine visits, it's hard to listen to the lungs, or you can't use your sense of smell. So again, telemedicine providers are going to have to be careful and have to be mindful of when potentially a live visit may be required by the standard of care. Also, documentation regarding telemedicine visits is going to be very, very important going forward. It is recommended providers timely and adequately document their telemedicine visits with patients. Some takeaways about telemedicine include, number one, it's here to stay. Number two, it can be great for providers as well as patients. However, providers need to be mindful of the diagnostic accuracy of telemedicine. They need to be mindful of technology issues. They need to be mindful of informed consent issues. And they need to be mindful about timely charting and adequate charting regarding telemedicine visits. Another potential medical legal issues that we're concerned about deal with elective procedures. Many states have issued emergency orders suspending elective procedures. However, soon the restrictions will be lifted and providers need to continue to exercise good judgment when performing elective procedures. Some possible future medical legal issues or concerns with elective procedures include scheduling too many elective procedures in one day for financial gain, rushing through elective procedures for financial gain, or performing elective procedures while fatigued for financial gain. Last but not least, another medical legal issue for COVID is provider distress and/or provider burnout. For example, many providers during the crisis are undergoing financial hardship because patient visits and/or surgeries have decreased. Therefore, their cash flow is down, and that's causing them a lot of stress. Also, during the COVID crisis, many are working long hours. They're unhappy with their personal protection equipment. They're fearful about catching COVID and/or they're fearful about exposing their loved ones to COVID. These fears could cause many healthcare providers in the future to leave healthcare. So that's a concern. I end with the following thoughts, or 2 points. Number one, don't be alarmed by the items that I discussed. Everything's going to be okay. Number two, for all the healthcare providers and healthcare systems out there listening to this webinar today, thank you for your leadership. Thank you for your dedication, and thank you for your sacrifices. You are all true heroes.
Thank you, Mike, for those outstanding remarks. Kyle, from the perspective of a defense attorney, what sorts of issues are you starting to see?
Well, thank you, Tom. First of all, I'd like to say thank you all for attending. I think it's a really important time. So people like myself who are into legal futurism have said and saying for years that there would be a paradigmatic shift in not only the practice of law, but the business of law. And when we all thought it would be 5 to 10 years away, we were wrong. It was 5 weeks ago. That's the key point, I think, here, that defense lawyers are going to have to reevaluate not only the way they do business for their healthcare clients, but reevaluate they do business within the context of their own firms. Right now, it's rare that we've had in the practice of law servicing the needs of the healthcare industry an incident or event that requires us to completely change our footing from a circle the wagons and traditional deny and defend mindset to a preventive model of lawyering by caring for the caregiver now in a completely model of prevention of litigation. And so the most important thing I heard, Rick Boothman was on a call with Tom Gallagher and I and Mike Severin a few weeks ago, and he had a really interesting point, and I told him at the time, full disclosure, I was going to steal it from him. And he said, this is a great time for lawyers to reevaluate the conversations they have with their clients, as opposed to saying, what kind of cases are you going to give me, or what, that type of thing. They need to ask their clients, what is important to you? And as right now, we do not have a massive influx in litigation. We have most courts that have paused their trial dockets, paused the discovery docket. We really, as defense lawyers, have an incredibly unique opportunity to address the paradigmatic shift that has already occurred and refocus our efforts on being collaborative and entrepreneurial with our clients, working from the context of our ethical obligations to our healthcare providers to meet their ethical obligations to their patients to explore and prevent patient harm from occurring during this unprecedented time. So I'm seeing on the front lines of dealing with healthcare systems around the country is we all believe that long-term care will be hit the hardest. They rely less on medical judgment and more on routine and heavily regulated activities and no pay provisions of CMS than what even our hospitals and physicians do. So I think that's one of the most important factors. We're seeing access to care issues. We're seeing a real concern whether the courts may extend EMTALA to an area it's never been in before, which is electronic communications only. Is that sufficient coming to the campus of the healthcare provider to invoke certain federal statutes to guarantee access to care? It's been hit on a little bit by Marcia and Leilani and Mike as well. Communication challenges. What we're putting in the medical chart is incredibly important. And I think my biggest concern is in our need to be in the preventive model as defense lawyers to prevent litigation from occurring is counseling and working with our clients in our health care systems to make sure that our charting is being done in a way that is kind to one another, where we're not attacking fellow healthcare providers. We're not, our healthcare providers are literally under unprecedented stress, and we want them to find appropriate ways to meet those and get rid of that stress, as opposed to pouring it out in the narrative portions of plaintiffs' medical records and EMRs, where it can never come back. Once it's in, it's never coming out. And so other things, court intervention in vent protocols, experimental treatments that are being done by some primary care physicians with no proper, outside their scope of practice, poor infection control practices. And one of the biggest things that concerns me for when we're going to see litigation that may come from this is social media posts by providers. Just like some people air their grievances within the context of the EMR, we always see healthcare providers and have a concern that frustration bubbles up into social media posts they make themselves. We're already seeing that, and we're trying to address that in a way of, without adding to the stress of the healthcare providers. And I think it's going to be really important for healthcare systems to give the caregivers a stress outlet so they can communicate their concerns, their frustrations, and the grievances they have about perhaps the lack of preparedness of their facility. And risk management is the way to do that. The use of the defense lawyer in the context of working with caregivers who are stressed out and prone to communication blunders or social media posts, the privilege that defense lawyers can exert over those communications is really important. And the defense lawyer has an absolute vital role in learning how to partner with the communication resolution programs that are sweeping the country and becoming the standard of care. So I'd like to, a couple other things I think in the prevention model is, I think we should be working with our clients in meeting their needs. When we ask them the question of what can we do for you, what are you needing, is working with the greater defense area and coming up with brief banks so we can anticipate the types of claims that will be made, so we can reduce the legal spend of these institutions, so we can have common pleading pools to draw from, so we're not, all the lawyers aren't recreating the wheel and unnecessarily putting expense on our healthcare systems. And then lastly, we've been coordinating for my office in providing free of charge consent specific to COVID-19 now that many states are opening up and allowing elective procedures. And so one of the things we encourage people, and if you need these, reach out to Tom has them as well as myself, general consents that aren't case specific, but are COVID-19 specific, that are really used as a supplement to the consenting process, because there's so much representations that we cannot make because of the fluid nature of the development of this viral outbreak. So we need to be very mindful that they're in our ethical obligations as healthcare providers to communicate known risks, but also unknown risks. And it's important that they communicate what we don't know and what we cannot know right now. And so it's important for patients when they're making these autonomous decisions to know that they are accepting a burden of receiving this care at a time when assurances cannot be made that it's safe.
That's great, Kyle. Thank you so much. And as Kyle hinted at, one of the programs the collaborative is actively planning and hopes to be able to stand up in the next few months is an alliance of healthcare attorneys, both defense and plaintiff, to help them understand how can they constructively engage in the CRP process. So much more to come about that. Thanks so much to everyone who's sending in questions. Keep them coming. I'd like to start with a few of my own. And Leilani, one of the things that's been striking to me as a primary care provider is how empty our schedules are right now. Patients, I think, are really feeling anxious about coming into the clinics, coming into the emergency rooms. How would you recommend we begin persuading patients that it's safe to have primary care and other elective types of medical interventions? I think you may be muted, Leilani.
You guys can't read my lips? I'm sorry about that. So I'm always going to be an advocate for explaining things to patients and families. And as I understand it, there are a lot of efforts going on to make sure that our hospitals are safe. At Stanford, every patient is tested for COVID. Every staff member is tested for COVID. Those patients are isolated. They are far away from other patients. And so communicating all of these efforts of what's going on is really helpful and hopefully will be reassuring. I think it also is relevant and helpful for patients to understand that testing has shown that healthcare providers tend to have a lower incidence of infection rates than people in the general community. So actually going into a hospital is safer than being out amongst the community. And then I also think it would be important to discuss with patients what are the risks of continuing to delay a procedure. That potentially could be a problem going forward is, well, I didn't know if I waited longer, this would cause this consequence for me. So I think explaining all of those things to patients informs them of a circumstance that allows them to judge the circumstance and make decisions for themselves as best they can.
Thank you, Leilani. Marcia, have you had any experiences yet communicating with patients or families and helping them address their fears about the safety of coming for non-COVID care?
Yeah, I haven't had any direct experience in that, Tom, but I can tell you that our approach at University of Washington is pretty similar to Stanford's in the sense that we've tried to take all the appropriate precautions for patients and recently have started kind of a direct kind of campaign communicating directly to patients about the safety measures we've taken. So patients now know that when they've received an email from our system. Basically, if they come to our facility, the people are screened when they come in. All of our care providers are masked and they are being tested, and that's being monitored, as well as every patient that comes in. So we are also moving into doing offering serology, antibody testing to all of our employees. So we're trying to be very transparent about those efforts with our patients. So, we did that directly. They hear that when they're being screened coming in. They know that they are offered masks when they come. That's not required, but we're certainly offering it to all patients who enter our facility. And we're also beginning to use social media to push that out so that it's very transparent and clear to the community that we are creating as safe as possible space for them to receive care.
That's great. And Marcia, sticking with you for just a minute, it is intensely frustrating for providers when they have a COVID positive patient who is either unable or unwilling to comply with recommendations to quarantine. And so it sounds like you've gotten a bunch of calls from providers who basically want to call the police or somehow detain that patient and force them into isolation. How do you respond to phone calls like that from providers?
Well, I suspect I'm speaking for my team who's taken most of these calls. I've been more on the policy side of this, but it's frustrating to the providers, particularly since this crisis is being led by our infection prevention specialists who work so closely with public health on a day-to-day basis, and they're well aware of the fact that public health can detain patients, and they're wondering why they can't, for the public good and for the safety of employees and just anyone else that come in contact with. What we did was kind of work with public health in order to create messages and a tie-in so that we give our providers some way to constructively deal with their concern. And in our state, only the public health department can detain a patient. But now if a patient's leaving at the end of the middle of the night from the ED and they're COVID positive and homeless, or they have a substance use disorder, or whatever it is that would cause them to not self-isolate or self-quarantine, we have a 24-hour crises coordinator at public health, and we've given them the out for that. We've also provided them with information and really suggested, like, if it's an inpatient, let's start with what's causing them to be non-compliant and approach this clinically and compassionately with the patients and appeal to their better instincts. And I think that's been successful, not 100% because we know we're going to have non-compliant patients, but the anxiety around this question has certainly died down.
Thank you, Marcia. Mike, if a patient delays seeking recommended care or reporting symptoms that were persisting because of COVID concerns, does that mitigate the potential provider liability for a delayed diagnosis in some way? How do you help providers understand sort of the impact of patient contribution to delay in diagnosis around COVID concerns?
Sure. Yes, I think if a patient delays reporting symptoms or fails to follow recommendations, it could very well likely mitigate potential provider liability. Specifically, the provider could claim contributory negligence or comparative negligence should the patient file suit against the provider. So again, my suggestions to providers, healthcare providers in this kind of scenario is, again, kind of classic risk management. Definitely chart in the patient's file your recommendations, and if the patient is not following those recommendations, or you find out that the patient during your history and physical exam of that patient that the patient delayed reporting certain symptoms, definitely chart that in the patient's chart would be my suggestion to the provider.
So that's great, Mike. And I'm intensely interested in this issue of charting, and we've written some about charting of provider concerns that can be not helpful. And Kyle, you mentioned the issue of inappropriate social media posts. For those of you who didn't see, earlier this month, there was a very nice article in the New England Journal called Chart Warfare. Kyle, what do you think providers should do if they believe that COVID-related restrictions prevented them from delivering what they thought was optimal care? Is it okay for them to note those concerns in the chart?
Absolutely. Objectively, I think it's appropriate to communicate available resources to patients and then chart in the medical record objectively and accurately, including that the patient had an opportunity to ask questions and have them answered. In kind of furtherance of what Mike said, most of the people who probably may be watching are too young to remember Dragnet and Just the Facts, Joe Friday. That's what we should have the mindset of, just the facts. Where we get ourselves in trouble as healthcare providers is when we we confuse the subjective concerns that we have about why we have challenged resources, and we misconstrue that as objective concerns. And what we need, it's okay, I think, to tell them, we have major PPE restrictions, or we have access to resources issues that are brought about by COVID-19 that are germane to your care, and objectively put those in the record. And if there's ever any doubt, I think that's where caregivers need to consult risk management and get some guidance, not in a circle the wagons way, but in a how to better educate the patient on what those restrictions to resources are.
Marcia, I know you have chart war nightmares as a risk manager. What advice do you give to providers who really are frustrated that they feel like I couldn't provide the care I wanted to because there were restricted resources or some other challenge related to COVID and feel like I want people to know that I should write a note in the chart? What do you tell providers?
Sorry, I know you can't hear me when I'm speaking on mute. What we usually tell providers is, one, I agree with Kyle, to chart objectively and factually about the situation they're in, but also to work more constructively to deal with their concerns. We have a robust quality improvement system, and the place where they should be airing all of their concerns are within that structure so that we can hear the concerns and deal with the problem from a system perspective, because it usually is a system perspective, or to get the message out. And I know, like during the COVID crisis, the same transparency that we want to promote with patients is just as important for our care providers to hear. I know we're having regular town halls led by our clinical leaders every Friday, and those are really places where clinicians can get their willies out, if you will, in terms of being, the concerns they have about the ability to provide care in the environment and to provide direct feedback to the leaders who are making these rapid fire changes. So I think it's a combination of using our existing structures to deal with more routine questions, appropriate and consistent documentation about what's clinically appropriate in the medical record, and then also providing really good support for the care providers in this situation. I think a lot of the jousting or chart wars we see are born out of moral distress and feeling like they're helpless and not able to help patients. And so we need to help our care providers through this as much as our patients.
Thank you, Marcia. And I have one last question that I'd like a brief response from each of the panelists about, and then we'll turn to some of the great questions that have been submitted. What do you think the implications of COVID are for communication and resolution programs? Let's go in the same order that we presented. And Leilani, you led off and noted you think COVID is going to be sort of an important stimulus for communication and resolution programs. How do you think the two interface?
Well, I think CRPs could be a way to flatten the curve of what could be the coming litigation related to this. Just going back to what I said at the beginning, I think this is a profound stressor on absolutely everyone essentially on the planet, and those are going to roll forward. And the questions that patients and families do not get answers to are not going to go away. And so CRPs have created and provide a structure to have those conversations, to answer questions and manage expectations around unexpected outcomes. And so those structures are already there, and they're just going to be more and more needed because of the fallout from everything that's happening.
Thank you, Leilani. And Leilani, maybe you can have a look at the chat box. Michael Victorov has two really good questions about communication that I'm going to circle back to you on in just a few minutes. Marcia, what do you think the link between COVID and all of the ways it's affecting healthcare and CRPs will be?
Well, one of the things that I think will be an outcome of this is just the normalization of being transparent. There's so much about infection prevention and control practice that has always involved direct communication to patients tied to their ongoing clinical care, and more of a public transparency because of the connection to public health and public health reporting that I think has just been a really good demonstration in a broad way about how communication and resolution programs really work to both further the care of an individual patient, but also to support the communications that are needed and the transparency to make a CRP work.
Thanks, Marcia. Mike, how do you think COVID and CRP overlap?
In simple terms, I think now more than ever, we're going to need open, honest, transparent, and thoughtful communications with patients when unanticipated outcomes develop during the treatment of patients. Real simple.
That's great. And Kyle, what are your thoughts? How do COVID and CRP relate to one another?
I think it's going to be an accelerant for sure. And I agree with what Mike and Leilani and Marcia have all said. I think one important point is that defense lawyers, and I've been to many seminars around the country where defense lawyers have had a chance to ask questions of presenters like Leilani, who get up and do an amazing job of talking about the human implications of this. And defense lawyers have felt, I think, historically, like they're on the outside looking in on CRPs. And I think one of the exciting things to look forward to is the opportunity for the defense lawyers, the role that we have in protecting our healthcare clients can be done and will be done from an inside perspective. And the role we play is vital to CRPs being successful. But what's going to happen because of the financial crisis that is coming as the second wave of this on our healthcare clients, the whole concept of litigation being defended with historical profit centers to law firms that are completely based on inefficiency and circle the wagons and extend the length of the case is going to be rejected by our clients as not sustainable for their business practices. So we as defense lawyers are going to have to take ownership of the important role we have and operate within the system as opposed to without the system in a critic standpoint. We need to, if there's things that need to change or points of view and perspectives that need to be addressed, we have an important role in the collaborative, and the CRP process is asking us in to be involved with it. We're going to have to embrace this new role, and hopefully the Defense Alliance will give us that opportunity to take it to more and more law firms.
Thank you, Kyle. For those of you who are watching the chat box, Alan Lembitz submitted a very thoughtful comment about people being less likely to sue individuals in full PPE, but more likely to sue large faceless systems. We need to put a face on the system and take ownership of crucial conversations. Alan, I don't know if you're able to unmute yourself, but if you are, can you expand on that comment for just a second? We'll see if we can hear from Alan. While we're waiting to hear from Alan, Michael Victoroff submitted several interesting questions and comments about how we can improve the way we communicate with patients and families. Can we think about ways and formats for preparing explanations we're going to be giving later? What disclosures and explanations should we be providing now? Does it make more sense to put an emphasis on early and ongoing communication with patients and families? Leilani, maybe you can respond to that. And then Alan, I think we've unmuted you and we can hear your thoughts. What would you suggest, Leilani, in response to Michael's thoughtful questions about communicating with patients and families?
Well, I think early and ongoing is the best way to go about it, though I recognize that's not always possible. I would suggest coordinating with your patient relations teams, with your risk management teams, to start anticipating what kind of questions are going to be coming forward. So we're starting to think about what is going to be our response to patient questions about PPE. So why wasn't the doctor wearing a mask when my child's ankle was sewn up, or you name it, whatever. But I would just advise looking ahead in anticipation of what some of those questions are going to be. That's where having a CRP where everything is not placed as a responsibility on the provider, but you can also work within the larger system to take advantage of other roles that already exist to help you. That's, yeah.
Yeah, thank you, Leilani. And we'll circle back to this issue of communication in a few minutes if we have more time. Alan, I think you're unmuted now. Do you mind expanding just a little bit on how you would recommend we go about putting a face on the system and taking ownership of crucial conversations? Alan, can you unmute yourself? We'll have to have him send in his thoughts by comment. Oh, there we go. Alan, are you able to share your thoughts?
Yeah. So I'm in full congruence with what Leilani said, which is people are frustrated, providers are frustrated. And, once we get over the crisis mode and feel like we're more stable, that's when the blame shifting is likely to happen. And there'll be a great number of conversations, both from the providers, why they weren't protected, while they felt that they couldn't provide the care they needed to the patients for systemic reasons, and obviously from the patient's side as well. I think having, as you've been advocating for years, Tom, to having skilled training and professional conversations, it's not an acquired skill necessarily. They're good communicators and they're not so good communicators, and but this is the time for systems to really ramp up. It's not about public relations. It's really going to be about their lifeblood. And then the last comment I had was, I don't think after the financial stress in private practice, you're going to find too many people who are practitioners who are going to think it's worth it. I think the shift either out of medicine entirely or into a employed role will only make it even more of these system factors, and the plaintiffs are going to be searching for system issues, not individual issues. Thank you for giving me that time.
Yeah, thanks so much, Alan. Marcia, Jackie Hall asked about recommendations for adherence to ADA Rehab Act when it comes to COVID-disabled patients and allowance of visitors. How do you go about, do you need to allow more than one visitor and allow them the ability to come and go? How have you been thinking about COVID care with disabled patients?
Right. Well, first of all, disclaimer, I'm certainly no expert on discrimination law, so I want to be clear about that. But that is something that, when we got the letter from the disability rights law firm, they actually had some really good suggestions, and I started kind of working back through some of the things we were doing to make sure that we were considering those things, that we weren't just slapping things up on our webpage without making them accessible and that sort of thing. But in terms of this particular question, when we wrote our visitor policy limiting to one visitor, we also allowed for accommodations to be made. And I think that's, you have to look at each situation. If a patient, is not able to do their activities of day, whatever they need to do without the support of an additional person, we would allow that other person in. We would make an accommodation. And I think that's just true generally in discrimination matters.
Mike or Kyle, do you have anything you'd like to add on the issue of providing COVID care for disabled patients?
I'll go real quickly because I think it's a great point. It's certainly, it's not just ADA either. There's the Anti-Aging Discrimination Act. There's other acts as well that can be impacted. Right now, I think we're in the safest part because most states are under executive orders that are really we can defer to. The bigger changes as things begin opening back up again. And I think Marcia has been a thought leader at her facility, which is one of the first hit in the country, to how do we go ahead and do this. So I think one of the most important factors is draw from the experiences of the people like Marcia and Dr. Gallagher here who've been on the front lines already. And as it sweeps through the rest of the country, we can learn from the lessons of policy and protocol that have been established by the people who have already kind of lived through the first wave.
That's great, Kyle. And for the panelists, we're going to close with asking people to respond to Sherry's question about positive changes related to COVID that they hope are sustained. But while you're thinking about that, Mike, did you have any thoughts that you wanted to share about COVID and appropriate care for disabled patients?
Nothing further to add other than what Marcia and Kyle had said. I would just further add that, when in doubt, apply common sense. Exercise reasonable judgment.
Yeah. Tom, before we start, I just wanted to follow on something that Kyle said, is that the University of Washington actually has a public-facing website where we've posted a number of our policies and procedures that we've put together. And I would love it if you could share that with the group at the close of the webinar.
We'll be sure to send that out. And so thank you for mentioning that. And so let's end in reverse order. There have been a lot of challenges with COVID, but there are some positive changes in healthcare as well. What is an example of a positive change that you've seen that you hope can be sustained going forward? Kyle, let's start with you. Any positive changes that you hope that will stick?
I think access to care via telemedicine is something that it had its paradigmatic shift as well. And the other thing I think is the defense's role in working on existing problems, not just waiting around for the filed lawsuit to happen. That's been hopefully a sustainable change that will carry us once this is over.
Thank you, Kyle. Mike, what positive changes are you seeing that you're excited about and hope will carry forward into the future?
Number one, more of a focus on better communication with patients. Number two, more focus on the informed consent process. I think that's a positive. Those are two positives that I see out there.
Marcia, how about you? What are some positive changes? And I know, you've probably just started to be able to think non-COVID thoughts. I know it's just been all-consuming for you for an extended period of time, but have you seen positive changes that you hope are sustained?
Yeah, I would echo what Kyle said about telehealth. I really think the access to care through that modality has been accelerated rapidly. I know we had been working on that for a long time, and the acceptance is just going to be there, I think, in the community, and there's going to be more of a demand. But I also, as I mentioned earlier, I think in the way that infection prevention practices and their visibility as leaders, around transparency and patient care and the communication that's done around infectious diseases, I think is just a really great launch pad for furthering CRPs.
That's great. And Leilani, you get the last word. Are there positive changes that you're seeing that you really hope we can sustain?
Well, I think the national dialogue about frontline healthcare workers being heroes is an important thing that I hope will carry forward. I think something that I hope becomes clear and we all can remember is that we only are as healthy as the least healthy person around us. The way that this has spread and has made us all vulnerable is a reminder, I hope, that taking care of people around us is a good way to take care of ourselves and the people we love. So that's something that I think is happening already and that I hope will continue to carry forward.
Thank you all to our outstanding panelists. Great presentations. We went through a lot of content in very short order. We thank you very, very much for attending. If you'd like more information about the collaborative, the website is there on the screen. We'll have the recording available next week. UW Medicine's COVID resources are listed here. With your permission, we'd love to add all of you to the collaborative's mailing list so that you're aware of upcoming webinars and other events. Please let us know if you don't want to be on that email list. We'd also love to get any questions or topics that you'd like to see on upcoming webinars to the email there. And then graciously, all of our speakers have listed their email addresses. And the whole point of the collaborative is creating a community that can work together to identify and respond effectively when patients have been harmed by their care. And so we would love to hear more from you about the challenges that you're experiencing and how we can work together on solutions. So thanks very much for joining us. Thanks to our panelists. Hope everyone has a great weekend. Bye-bye.